Welcome. In this session, we'll be discussing benign intraocular tumors. We have already discussed a few of them in the previous sessions, and we'll be discussing the remainder in this session. We have discussed uveal nevus and melanocytoma among the benign melanocytic uveal tumors, and among the benign non-melanocytic uveal tumors, we have choroidal hemangioma, choroidal osteoma, uveal leiomyoma, uveal neurilemmoma, and uveal choristoma, which we will be discussing in this session. Choroidal hemangioma is a choroidal vascular hamartoma, and it can be of two types: diffuse choroidal hemangioma, which we have discussed in the session on phakomatosis, and circumscribed choroidal hemangioma, which appear as oval to round discoid reddish orange lesion, which occurs mainly in the posterior pole and usually involving the macula. Circumscribed choroidal hemangioma, unlike diffuse choroidal hemangioma, does not have any systemic association. Early on, a circumscribed choroidal hemangioma is difficult to distinguish from the surrounding fundus because of similar color. Later it becomes more distinguishable because of degenerative changes in the overlying RPE, as we see in this picture. The lesion is better detected by transscleral transillumination while examining the fundus, with the transscleral transillumination highlighting the entire lesion, by slit beam examination of the fundus with the lesion appearing to glow under the effect of the slit beam, and in the infrared image of the fundus as provided by most OCT machines, in which the lesion appears dark as compared to the surrounding fundus, as seen here in this photograph. Choroidal hemangiomas can cause visual loss from degenerative changes in the overlying RPE, cystoid macular edema, and serous retinal detachment. However, choroidal hemangioma is not known to have any malignant potential. On ultrasound examination in the A scan, a choroidal hemangioma shows a high spike from the anterior surface of the tumor and high and broad echoes from the interior of the tumor, thus demonstrating high internal reflectivity of the tumor. So this is in contrast to choroidal melanoma, where the echoes from the interior of the tumor has low amplitudes. B scan shows a fusiform to biconvex mass lesion with high internal reflectivity. However, choroidal excavation and acoustic shadowing, which are characteristic of choroidal melanomas, are not found with choroidal hemangioma. On optical coherence tomography, a choroidal hemangioma shows a smooth dome-shaped elevation with tapered borders in the region of the tumor and a very low internal reflectivity from the choroid in the region of the tumor. The infrared fundus photograph provided with most OCT machines can also help in identifying the extent of the tumor, as we have discussed and as we see in this photograph, and cystoid macular edema, serous retinal detachment, and degenerative RPE changes can be detected in the OCT. Fundus fluorescent angiography shows relatively rapid filling of the large vessels of the tumor in the early choroidal filling phase, and in the later phase there will be staining of the tumor, and cystoid macular edema can be detected if it is present. Indocyanine green angiography is the preferred diagnostic modality for choroidal vascular lesions. Please see an image of ICG in choroidal hemangioma on the net, because I could not find a copyright-free image. A choroidal hemangioma on ICG shows filling of the large choroidal vessels of the tumor early on the angiogram, which becomes maximal at 3 to 4 minutes, as shown here in this diagram, followed by the characteristic washout of the dye from the center of the tumor, leaving behind hypercyanescent margins, as represented here in this diagram. This central dye washout is rarely found with other tumors, and absence of this feature should suggest infiltrative lesions. Differential diagnosis of choroidal hemangioma is the same as that of any other amelanotic choroidal mass lesion. Asymptomatic choroidal hemangiomas do not require any treatment. Treatment indications include exudative retinal detachment and cystoid macular edema. Treatment modalities include photodynamic therapy, which is the current treatment of choice for circumscribed choroidal hemangioma, but multiple treatment sessions may be required. Radiation therapy is indicated when the tumor does not respond to PDT, and it is preferred over PDT for diffuse choroidal hemangioma. and radiation can be delivered either as brachytherapy, charged particle therapy, or external beam radiotherapy. So this is a situation where radiation therapy is a treatment option for a benign tumor. And it has been found that anti-VEGFs do not work in cases of choroidal hemangiomas. Choroidal osteomas occur due to formation of mature bone in the posterior portion of the choroid, and it is usually detected by third decade of life, and most patients are females. 1/4 of choroidal osteomas are bilateral. Choroidal osteomas usually occur in the juxtapapillary region, partially or completely encircling the optic disc, as seen here in this photograph. It can extend up to the macular region, and it appears as a yellowish to orange plate-like lesion with very well-defined, smoothly curved pseudopod-like margins. The very well-defined margin with pseudopod-like projections is the characteristic feature which helps to clinically diagnose choroidal osteoma. Choroidal osteomas can also have changes in the overlying retinal pigment epithelium in the form of pigment clumping or fibrous metaplasia. Choroidal osteomas have been shown to grow very slowly with time, and it may be complicated by development of subretinal neovascular membrane. However, it does not have any malignant potential. Ultrasound examination shows very high echogenicity in the region of the tumor with characteristic acoustic shadowing of the orbit posterior to the lesion. CT scan shows a hyper-intense plate-like lesion in the region of the tumor. This will be OCT. Treatment options for choroidal osteomas are limited, and visual prognosis is usually poor in these patients. Uveal leiomyomas arise from cells having smooth muscle differentiation, and they are mostly found in iris and ciliary body, the structures in the eye known to have smooth muscles. And uveal leiomyomas in these structures appear as a tan to white colored mass resembling amelanotic melanomas. However, they do not have episcleral sentinel vessels or tumor nodules on the epibulbar surface, which are characteristic of ciliary body melanomas. Uveal neurillemmomas arise from Schwann cells of branches of the trigeminal nerve, and they are usually found in the choroid, in which lie the long and the short posterior ciliary branches of the trigeminal nerve. Uveal neurillemmomas appear as discoid hypomelanotic lesions, but they do not have serous retinal detachment, unlike choroidal melanomas, and unlike choroidal melanomas, they do not leak on angiography. However, they are mostly diagnosed after enucleation for a suspected choroidal melanoma. Intraocular choristomas are very rare tumors, and multiple tissue types have been reported to occur within intraocular choristomas. Among the benign retinal tumors, we have the retinal neuroectodermal tumors and the retinal vascular tumors. We have already discussed the benign neuroectodermal retinal tumors, among which we have astrocytomas arising from the retinal nerve fiber layer, retinocytoma arising from the retina, adenomas and simple hamartomas arising from the retinal pigment epithelium, and combined hamartoma of retina and retinal pigment epithelium, which is a mixed tumor arising from the retina as well as retinal pigment epithelium. Among the benign vascular retinal tumors, we have already discussed retinal capillary hemangioblastoma and racemose angioma in the previous sessions, and in this session we will discuss retinal cavernous hemangioma and retinal vasoproliferative tumor. The term retinal cavernous hemangioma should be distinguished from retinal capillary hemangioma of von Hippel-Lindau disease, which we have discussed in the previous session. Retinal cavernous hemangioma is considered to be a congenital lesion which appears as a grape-like cluster of vesicles in the retina and infrequently over the optic disc. They neither leak nor do they develop overlying exudative retinal detachment, but overlying hemorrhage and gliosis can occur. Fluorescein angiography shows low filling of vesicles with characteristic layering or separation within the vesicles, with fluorescein layering over sedimented erythrocytes below, as shown here in this diagram. Cavernous hemangiomas of the retina do not require any treatment. Retinal vasoproliferative tumors or VPTs are usually detected in the 3rd to 4th decades of life. and they are a proliferation of glial tissue and retinal blood vessels. Most of them are idiopathic, but some can be secondary to inflammatory, traumatic, or degenerative retinopathies. Retinal VPTs appear as a white to pink elevated mass with an irregular network of blood vessels on its inner surface. Idiopathic VPTs usually occur in the fundus periphery, often inferotemporally, but secondary VPTs can occur more centrally, as seen here in this photograph, and they are often misdiagnosed as a mushroom-shaped amelanotic choroidal melanoma, particularly when they occur centrally in the fundus. Retinal VPTs can be multiple, particularly when they are secondary to pre-existing retinopathy and they do not show feeder and drainer vessels. They result in exudative changes in the overlying and surrounding retina and can lead to epiretinal membrane and cystoid macular edema in the macular area. Fluorescent angiography shows staining and leakage from the lesion, and treatment is difficult and may require multiple sessions of triple freeze-thaw cryotherapy, laser photocoagulation, photodynamic therapy, and radiotherapy. To sum up, choroidal hemangiomas can be circumscribed or diffuse. Choroidal hemangiomas can be difficult to differentiate from the surrounding fundus, especially in early stage. Choroidal hemangiomas cause loss of vision by causing serous retinal detachment, cystoid macular edema, and degeneration of overlying retina and retinal pigment epithelium. Choroidal hemangiomas show high internal reflectivity on ultrasound, low internal reflectivity on OCT, early filling and late staining on fundus fluorescent angiography, and early filling followed by characteristic late central dye washout on indocyanine green angiography. Choroidal hemangiomas can be treated by photodynamic therapy or radiotherapy. Choroidal osteomas appear as plate-like yellowish to orange juxtapapillary lesions with pseudopod-like margins. Choroidal osteomas are intensely hyperechogenic on ultrasound with shadowing of the orbit posteriorly, and patients with choroidal osteomas involving the macula usually have a poor visual prognosis. Thank you for listening.